Hey everyone, I knew my dogs were going to start barking as soon as we were about to get started. That's exactly what happened. Sorry, 1 second. Oh, the joys of working from home with 2 kids, 2 teenagers, and 3 dogs. So, hi everyone. I'm Marcia Anderson. I'm Korean Anishinaabe. I'm a public health doctor. I have not been on StreamYard since our last episode of COVID Combos at Sunshine House. So far, I'm not yet convinced about whether rather talk about COVID or monkeypox, but I guess we will see how this goes and how it unfolds in the months to come. I'm joined today by 4 of my other public health physician colleagues, 2 of whom work at Manitoba Health and 2 of whom work at the Winnipeg Regional Health Authority. So I'm just going to ask them to introduce themselves as well. And maybe we'll start with our colleagues from Manitoba Health.
Sure, I'll start. Hi, everyone. I'm Carol Kurbis. I'm one of the medical officers of health at Manitoba Health in the Communicable Disease Control Unit. So I'm a public health doc here, and I work with Santina Lee. So I'll turn it over to her to introduce herself.
Okay. Hi, everyone. So glad to be able to join you all here on this platform. It's my first time here, so this is pretty neat to see how it all works. I'm Santina Lee. Like others have mentioned, I'm also one of the medical officers of health that works in the Communicable Disease Control Unit at Manitoba Health with Dr. Kurbis, as she mentioned. I'm also an infectious disease doctor, so this is lots of talks about monkeypox in my community. So excited to share what I know with all of you.
Okay, thanks, Santina. And maybe our colleagues from the WRHA can introduce themselves now.
I'll go. My name is Bunmi Fatoye. I'm also a medical officer of health with the Winnipeg Health Region, and I'm glad to be here. I work in the area of communicable diseases, and this is one of the diseases of interest at this time. So I look forward to the awesome conversation.
Hi, I'm Pierre Plourde. I am also, as you've heard, a public health doctor, a white settler, and on a learning journey. And I am also an infectious disease doctor. And my public health portfolios include healthy sexually harm reduction, which includes sexually transmitted bloodborne infections control. And I'm also leading the travel health and tropical disease team, both of those areas having some indirect connection to the issue of monkeypox.
Okay, thanks all of you. So just to give folks a bit of an understanding of what we're going to do today, first of all, Carol is going to start off with an overview of monkeypox, where it's endemic, how it's spreading across the country, how it's transmitted, some of the treatment, and a bit about vaccines. We'll pause for some questions after that, and Santina will help answer any questions, especially any of the clinical questions at that point that might come up. You can put your questions into the comments, and I'll be keeping an eye out for them there. And then after that, Bunmi will be giving an overview of Winnipeg's current planning for the vaccine. And then after she's done with that, we'll open it up for questions again. And, you know, as with COVID, we started planning before COVID was actually here. That's what's going on with monkeypox too. So we're not going to have all of the answers today. We look forward to any recommendations or considerations you'd want to offer that would help guide the planning. But between the 5 of us, we'll share the best of what we know so far. So Jude, if you want to queue up Carol's slides, Carol, I'll go ahead and turn it over to you to start with the overview.
Great. All right. So thanks everyone again for inviting us to talk about monkeypox. It's a real topical issue that we're all paying very close attention to. And as Marcia said, we fortunately don't have any cases in Manitoba, but we know it's all around us, and so it's really important to share the information. So really appreciate this opportunity, and hoping to hear more from you out there on your thoughts and questions that you have, so we can help improve our communication and answer some of those burning questions that are out there. So just today, I'm going to do about a quick 10 minutes or so update that provides some basic information on monkeypox. And then we're going to pause for some questions, and then I'll turn it over to my colleagues from WRHA who will provide those local updates on planning. So I hope we have lots of time for questions, and looking forward to that interactive discussion, but I'll try my best to keep this short so we have lots of time for that. Okay, next slide. So monkeypox is not a new disease, even though most people here in North America may not have been aware of it. The monkeypox virus, it's part of the same family of viruses as smallpox. Those of us who are older, like I am, received a smallpox vaccine in our childhood, and that was stopped, back in the early 70s. The symptoms, they're similar to smallpox, but they tend to be milder. They're rarely fatal, although severe disease can occur. It is not related to chickenpox, though. It is a different family of viruses. So normally, monkeypox is a viral illness that is just seen in parts of Africa. And previously, any sporadic cases that we saw outside of Africa have usually been linked to animal exposures. In 2003, we had the first outbreak outside of Africa, and it was detected in the US linked to the pet trade. And at that time, pet prairie dogs were housed with other animals that were imported from Ghana in West Africa and became infected with monkeypox. And more than 70 cases of monkeypox were reported during that outbreak. Next slide. So in countries where monkeypox is common, it generally appeared to mainly spread to humans through that direct contact with an infected animal. However, more recently, there's been increasing numbers of cases related to human transmission, even in Africa. We don't really know what the animal reservoir is for monkeypox, but African rodents are suspected to be the main sources of monkeypox in the wild, which can include rats, dormice, squirrels, and other animals can also be infected, including primates such as monkeys, where the monkeypox virus was first identified. More recently, there's also been some sporadic detection of cases in the US, in Singapore, and the UK more recently, which may have been evidence of low-level circulation of the virus outside of Africa. However, we've also just come out of the COVID pandemic. Well, we're still in it to some degree. And so further spread may have been restricted by the pandemic measures that we all saw over the last few years. Next slide. So fast forward to May, we had a number of human cases of monkeypox that were identified in several countries where it's not typically found, including here in Quebec, Canada. And since then, the number of cases and countries impact has continued to grow, and these slides are likely already out of date because our numbers change daily. So next slide. So since May, we're over 12,000. I think we're now over 13,000 cases that have been reported to the World Health Organization from more than 60 to 70 countries, and it continues to grow. In Canada, over 600 cases have been identified, and the majority of those are in Quebec and Ontario so far. And we have not identified any cases yet in Manitoba. Next slide. So people usually develop symptoms about 5 to 21 days after being exposed to the monkeypox virus, usually within about 2 weeks. The first symptoms, or the first phase, are most commonly flu-like, and they can include symptoms like fever, headache, muscle aches, fatigue, swollen lymph nodes. But what we're seeing is that not all people seem to experience these symptoms first. And the next slide. So several days later, a rash appears that could affect really any part of the body. The rash progresses through 4 stages before it scabs over and resolves. So it starts as a macule, which is a medical term for a flat spot on your skin, which then becomes a papule, which is like a solid raised bump. Then that papule becomes a vesicle, which is a fluid-filled blister. Then it becomes a pustule. So instead of it being fluid-filled, the lesion's filled with a pus-like content. And then these pustules eventually crust and fall off with new skin healing underneath. So this rash can be quite painful for some and usually lasts between 14 to, even up to 28 days, which we know is a long time. The one thing, though, that we have noted is that not all the cases that are associated with this outbreak are presenting in the typical fashion. So we're seeing quite a wide variety of presentations. Some people present with only lesions in their mouth, on their genitals, or lesions around their anus. And these lesions tend to be developing at a site where a person was exposed to a lesion on someone else who was infected. The flu-like symptoms that I described on the previous slide, sometimes they occur prior to these lesions developing, or they could even occur after the appearance of the lesions. And some people may develop a more generalized rash, like on other parts of their body, and sometimes that rash evolves at different stages. So as a result, there can be a lot of variation in how people experience monkeypox, which will be part of the challenge in making sure we diagnose people quickly. Next slide. So a person is considered infectious for about 5 days prior to the onset of the rash and until all the skin lesions have resolved. And by resolved, I mean that the scabs have fallen off and there's new healed skin underneath. It can take between 2 to 4 weeks for this to occur, which is a long time. There are 3 main ways that monkeypox spreads during this time. So the first, which is the most common, is from person to person, which includes any direct contact with the lesions, or it can also be through respiratory droplets, such as when you cough or sneeze, or even when you're talking, singing, speaking. The second is through direct contact with contaminated objects, such as clothing or bedding. If there's scabs on your bedding, those are infectious. And then the third is from animals to human, and potentially vice versa. So the good news, though, is that monkeypox doesn't spread really easy. It generally requires prolonged respiratory contact, and by prolonged, I mean several hours, or direct contact with the lesions themselves. In this particular outbreak, person-to-person spread through direct contact with the sores or blisters is really the main route of spread. There haven't been many cases of household transmission or transmission to healthcare workers that have been reported. Next slide. So far, most cases to date have been identified in individuals who self-identify as a man and who report sexual contact with other men. However, it's unclear at this time if monkeypox can be transmitted specifically through sexual transmission routes, like the same way that syphilis and HIV are. We do know that close physical contact is a risk factor for transmission, which obviously does occur during sex. We know that having multiple sexual partners will increase the overall risk of exposure, and it also increases or contributes to further spread if someone with monkeypox has multiple exposures. These exposures can occur before the individual is aware that they have monkeypox, and some may only have a few lesions that they may not even initially notice. But, I will note, though, that in many cases in Canada, they've reported only one sexual contact in the previous 21 days. So anyone with a new partner or a partner who has had other exposures is potentially at risk. It doesn't, when you have direct contact with a lesion, all it takes is that one direct contact. But it's also important to note that though this virus that a lot of it is being spread through sexual contact right now, it can infect anyone through close person-to-person contact. There have been a few cases that have been identified in women and children. The virus doesn't target people, so any prolonged contact, not necessarily sexual, can pass it along. And, as we've said and tried to pass on this message, stigmatizing people because of a disease is never okay. And this disease is a public health concern for everyone, but not everyone has the same risk. So it's important to be aware of how the disease is currently spreading so you can assess and reduce your own risk. So based on the currently available information, cases have mainly, but not exclusively, been identified amongst men who have sex with men and who are seeking care in primary care and sexual health clinics. Next slide. So we really want anyone who is experiencing symptoms to seek health care, and we know that that's not always easy. But if you do develop symptoms, we would encourage you to contact a healthcare provider to get tested as soon as possible. You need to tell your healthcare provider if you've had contact with someone with known or suspected monkeypox. And you may need to remind your healthcare provider of your concern about monkeypox. Because we don't normally see it here, it's always a good thing to tell your provider what you're worried about. Your healthcare provider will need to take swabs of the lesions, and they're going to send them for testing. Generally, it doesn't take very long to get the results back, usually within a day or two. And just to note that monkeypox infection can look similar to other infectious diseases like chickenpox or herpes or syphilis. You really need to be tested for it to be diagnosed. We've had quite a number of tests done here in Manitoba, but so far they've all turned out to be something other than monkeypox. So even if you think you have monkeypox, it's quite likely that you don't. But we really need to test to make sure. Next slide. So treatment for monkeypox, there isn't a specific treatment. It's mostly supportive. And what I mean by that is that it includes, caring for the wounds, using pain control, and any treatment of other bacterial infections that might occur from those lesions. Most people don't require any more specific treatment, but there are some people who may develop more severe disease, and that risk is higher in people who have immunocompromised or young children, for example. So tecovirimat, which is also known as TPOXX, is an antiviral that was first developed to treat smallpox, but because the monkeypox virus is closely related to smallpox, TPOXX might also help treat monkeypox, and it can be used for severe cases. And we have several doses of that available here in Manitoba, should we require it. Next slide. So public health will follow up with all known cases and contacts. The cases do need to isolate at home until the lesions have resolved because they are quite infectious. While cases are isolating, they should try to follow all the measures to reduce the risk of spreading the virus to others in their household. So if they're in sharing a space with others, they should be wearing a mask and cover their lesions. They also need to avoid sharing objects or exposing other people to their clothes, their linens, their towels. But remember, it's not like COVID, which is transmitted quite easily. It's much more difficult to transmit monkeypox unless you have that direct contact with the lesions or a lot of prolonged face-to-face exposure. We also know that this is a really long time to isolate, and public health will work with the individuals to really support them during that isolation period. We'll be there to answer their questions, sort out any challenges you may have, with housing or food access. We know some people may not have a safe place to isolate, and public health can also assist with that. But it's really important to isolate to help prevent the spread of others. And when you do have exposure to other people, to take those precautions to try to avoid passing it on. But it is a long period, and we recognize that. For contacts, next slide, please. So the good news is that close contacts don't need to isolate as long as they don't have symptoms. But we do need them to monitor for symptoms for about 21 days after their last exposure. Again, public health will follow up with contacts to monitor them during this time, answer their questions, see if there's anything that we can assist with. They should also avoid to have any exposure if there's a case in their home as much as possible, similarly to what I talked about with cases. If symptoms develop, though, in the contact should call both public health and their healthcare provider to facilitate getting tested. And if they do have symptoms, then they'll need to isolate and avoid contact with people until we either rule out monkeypox, or if they're diagnosed with monkeypox, until their isolation period is over. And so that's one of the things that we would talk about if you were identified as a contact is, do you have primary care? Where can you go seek help if you do develop symptoms? And we can help sort through some of those issues as well. So vaccination, Immunocompromised, is a smallpox vaccine that's approved by Health Canada. Yes, thank you for advancing that slide. For use in adults who are assessed at being at high risk for exposure to monkeypox. Given shortly after the exposure, it may help prevent the disease, or it may make it less severe. It's not provided to people who do have monkeypox, but is offered to people who are contacts. So in Manitoba, individuals are currently eligible to receive the vaccine if they're a close contact of a monkeypox case, or if they've been exposed in the last 14 days in an area with an ongoing monkeypox outbreak, such as Montreal or Toronto, or any other jurisdiction that has active cases of monkeypox, and they meet the eligibility criteria from that area related to exposures. So just having a high risk of exposure, it's not just the travel itself. So this is referred to as post-exposure prophylaxis, where the vaccine's used after an exposure to try to prevent the disease from occurring or making it less severe. I will note, though, that cities like Montreal and Toronto with current outbreaks, they also are offering pre-exposure vaccine eligibility, which many of you may have heard about, where the vaccine is given before a known exposure to groups who are identified at risk. However, the global supply of Immunocompromised is very limited right now, and we don't currently have enough vaccine in Manitoba for pre-exposure prophylaxis. But this, as Marcia said, this is evolving. So this may change in the future as this outbreak continues to evolve. And we're putting in active plans to allow for this if the supply situation changes. And that could be at any point in time. So I would really encourage all of you to continue to listen to updates on monkeypox for news about vaccine eligibility. And my colleagues from WRHA will speak more specifically on some of the plans on that. Okay, next slide. So prevention, there are additional measures aside from vaccination that people can take to prevent exposure and transmission of monkeypox. Some of these may resonate more for some of you than others. So one thing that we just like to remind everyone is that you should always get tested for all STIs and take any medications prescribed. This helps your overall health and helps prevent, the onward spread of any kind of sexually transmitted infection. We would encourage you, if you're at risk, to check for any new rashes. If you see something or if you feel something, please consider getting tested early. We, suggest trying to limit the number of partners that you have close contact with, and limit as much as possible close contact during events. If you can't limit all, try to reduce the numbers. Condoms may help. They don't completely eliminate the risk of direct contact with lesions, as they could be anywhere on the body, but they also help at preventing other STIs, so they continue to be a good idea. Next slide. So there are a number of resources posted on the Manitoba Health website, and we continue to update the website as the information changes. We've also provided some link to community partner information, including Sunshine House, so encourage you to browse through the website. And as Marcia said, this outbreak really does continue to evolve, and we're continuing to learn new things about monkeypox. So as a result, I expect our approach and management to the outbreak, it's going to continue to change as we adjust to new information. And we'll try to update the website on any more recent updates that we can provide. And so I'll finish with that. Our last slide is just some links to more information. So you can peruse those various websites and hope that this answered at least some questions for you. So I'll maybe pause here and see if we can go to any questions.
Thanks, Carol. So I'll just remind folks that you can put your questions in the comments, and then I'll be able to ask them to our panelists. And while we're waiting for any questions to come in, I just have a couple that might be helpful to kick off some of the discussion. It seems to me that in the first few days, those general flu-like symptoms could look a lot like COVID. So I'm assuming we would want people to stay home, test themselves for COVID in that stage when they're having fevers, maybe muscle aches, headaches, things like that.
Yes, agreed. I think that's the problem with monkeypox is those first few symptoms. It could be anything, and and even with COVID, I think the main message that we're saying right now is if you're sick, stay home and try to avoid contact with other people. So I think that message applies to monkeypox or COVID.
And does everybody with monkeypox get a rash?
Well, that's a good question, and I'll turn it over to my colleagues to add to this. There have been a few, cases where they've detected it in people who have been asymptomatic when they've looked at, them being tested with other types of diseases. I'm not entirely sure we understand what that means. And I think, there's a lot that we're still learning about monkeypox where, I think up until now, we've assumed that everyone has a rash. Some people who have a rash may have it in places that they can't even detect. So that's the other thing, whether it's, somewhere where we just haven't noticed it yet, because there are some people who have really mild presentations, but I don't know whether Santina or Pierre has anything that they want to add to that.
Yeah. So I would say for the most part, monkeypox is really defined by the rash itself. And so it is quite unique to this infection, although as Carol was explaining, the rash can have some similarities to other infections such as chickenpox, which is a totally unrelated virus that causes chickenpox as compared to monkeypox. Now, so I think for the most part, like of all the cases that we are hearing about, and just remember, we haven't seen any cases in Manitoba yet, but what we've been hearing from the other provinces and other countries is that everyone who is feeling unwell does have a rash. What has been different with this particular outbreak that we're seeing with monkeypox is the type of rash. Because if you open a textbook and you read about what monkeypox is supposed to be like, it really talks about this widespread body rash, particular on the face, on the palms of your hands, and just kind of everywhere. But like Carol was saying, that hasn't been the case for a lot of people who have been experiencing monkeypox lately. For some people, they are telling us that they're having, well, not us, but other people that the doctors are seeing, telling them that they are experiencing this, widespread rash everywhere. But for other people, it has been very isolated to certain places like inside their mouth or their anus. So it is important to remember, just because you might have a rash that doesn't sound exactly like what other people are experiencing, but if you're worried about it, we really do encourage you to go get it checked out. And then the other thing I'll say is not everyone actually has all those initial day symptoms of like the fever, feeling tired, the muscle aches, those kind of things. So if you haven't had any of that, but you have a rash you're noticing, please do get that checked out.
Are people who have more lesions more infectious?
It's a really, really good question. And I don't think we really fully understand or know the answer to that right now. Although monkeypox is a virus that has been around for a number of years, there's still a lot that we don't exactly know about it. We know about smallpox a lot more. And so because smallpox and monkeypox are quite related, a lot of the information we know, we kind of, if we don't know about monkeypox, we try to take some of the things that we do know about smallpox and think that it might apply, but that might not be the exact case because they are different viruses. Mm-hmm. So all that to say is we don't know, like if you just have a few lesions, if that means you're less infectious compared to someone who has, say, like a full body rash. Either way, we do recommend that you cover up all those lesions as best as you can and try to avoid or reduce your contact with other people as much as possible for the entire time that you do have symptoms.
Okay. Yeah, I think that will be helpful for people to know, especially because it's a long isolation period, right? If they have lesions only in one part of their body that's easy to cover, they're still expected to isolate until those lesions are healed. Just to summarize, right?
Yes, that's correct.
Okay, and one more question that I have off the top of my head. If people have been watching the news, they might have seen pictures of hand, foot, and mouth disease and the headlines around hand, foot, and mouth disease spiking in Winnipeg right now. How would people tell the difference? Is it in who's getting infected and the population difference of who's impacted, or how would that be?
Having myself recently recovered from hand, foot, and mouth disease and having diagnosed it in my granddaughter, which is why I know what I had, and my son acquired it as well. We had a little cluster of it. I would first of all say by the rash appearance alone, I don't know how I would tell them apart. Really, the first thing is like you say, who's getting it? So, a 14-month-old child presenting with what looks like monkeypox rash with no travel history and no known contact with the current at-risk population is likely not going to have monkeypox, but is going to have hand, foot, and mouth disease, which, as you say, is occurring currently in outbreaks. It's a common summer virus, and there's a lot of it out there right now. And I suspect hand, foot, and mouth disease is more infectious than monkeypox. And that's why it's causing outbreaks in daycares, which is probably the source of the case where I ended up getting the infection. The only clinical difference I might think would help is the mouth sores that are quite painful, that are not universal, but I'm not aware that painful oral sores are typical of monkeypox, as Santina may know otherwise there, but they're certainly quite typical of hand, foot, and mouth disease, albeit not everybody gets that, but it's one of the tip-offs as well in children who stop feeding and drinking because of who can't communicate, who pre-verbal, who are having the sores in their mouth. But really the only way to tell for sure in an adult would be to test the lesions, to actually swab the lesions and isolate in the meantime until you have a confirmed diagnosis.
Yeah, I might just add. So what Pierre was saying in terms of like who's like sick and what kind of exposures they have, that's quite important. In terms of hand, foot, and mouth disease, now most people who are going to get it and have the rash related to hand, foot, and mouth disease are young children. Adults, as Pierre was explaining, can definitely get hand, foot, and mouth disease. But more commonly, if they get it, they have those like non-specific kind of flu-like symptoms, like having fever, feeling very tired or unwell. It's uncommon for adults to get the rash, but it definitely can happen. Now, as per the name, hand, foot, and mouth disease, typically the rash is inside the mouth, often at the back of the mouth, and then also on the hands and on your feet. But I guess like before this outbreak a few months ago, I would have said the monkeypox rash is supposed to look a lot different. It's supposed to, in one of its stage, when it's like a fluid filled or pus filled, it's supposed to have like a little dimple in the middle of it, like almost like a belly button, and that was supposed to be like how you could figure it out. But what we're hearing in the last few months is that the rash doesn't always look as expected. Stories that I've read online of people experiencing monkeypox is that something that first showed up looked like acne, pimples to them, and that's what they thought it was. But then over the course of a few days, what looked like acne completely changed its appearance. So sometimes that time we need, because time tells, it really, things will change as we go along. And monkeypox rash can really hurt. Now, in the past, we weren't really seeing monkeypox rash in the mouth, but we do know that some people more recently experiencing monkeypox have had some rash inside their mouth that are very, very painful. So really, I think the main message is if you have a rash or you're feeling unwell, try to limit your contact with others as much as possible and go see someone about it. Get it checked out, because it's really hard to tell the difference without a test.
Great. And I suppose that would be like even more important if you're someone who has traveled to an area where there's known to be monkeypox circulating, or once it starts circulating here in Manitoba too.
Yes, absolutely. Or even like if someone that you have close contact with, or you had a sex encounter with, and they traveled from somewhere that monkeypox is circulating, and then you start feeling unwell, keep it in mind.
Great. So I don't see any other questions. So why don't we go to Bunmi's presentation on the current plans for the vaccine in the Winnipeg region. Bunmi, you might need to unmute.
Thank you. Yeah. So good afternoon again. Please, can I have the next slide? So my outline is really going to briefly go through the vaccine, Immunocompromised, talk about the proposed and planned strategy for the vaccine rollout, and also briefly talk about the current response that we have in place. Next slide. So as mentioned earlier on by Carol, this is a vaccine that has been released and provided so that we can control the spread of the monkeypox monkeypox virus that we are experiencing now. One thing about this vaccine is that it's a weakened, created from a weakened virus, which is, as was mentioned earlier on, this virus is the smallpox virus, but it's very closely related to the monkeypox virus, and we expect that it will offer protection against anyone who maybe infected or maybe exposed to the virus. So keeping that in mind, the vaccine is not one of the vaccines that we routinely use in our immunization program. So we really have to be very cognizant of the vaccine characteristics, its storage, and its use, and all the guidelines that were released to us to help us roll it out accordingly. So most people will get one dose, which is an injection. And in some populations, the second dose may be required. And this is really based on a risk assessment of their exposure and and their situation at that point in time. And usually there's a 28-day interval between the first dose and the second dose. The vaccine has been in use in Canada over the past few months. In other jurisdictions. At least I would say over 10,000 doses have been administered in Canada so far, and we haven't yet come across any major side effect. There is ongoing monitoring of vaccine adverse effects, so we hope to hear anything if there's anything being reported, but thus there's none. But we need to expect the common side reactions we get following immunizations. This could be pain, redness, or soreness around the injection site, and also some symptoms such as fatigue or muscle aches and pains could also present post-immunization. There are two uses of this vaccine. One is called pre-exposure, which is before you actually get exposed to the virus itself. And there's post-exposure use, which is after you've been exposed to the virus, but you are yet to manifest or present with symptoms. Next slide. So in order for us to roll out this vaccine, we really needed to take into consideration certain principles that we felt will inform the process. First and foremost, we lacked data in Manitoba, so we needed to rely on data from other jurisdictions to really inform our plan going forward. Definitely from the current epidemiology, which is the data that we have from the jurisdictions that have cases, it's definitely a risk-based eligibility. So those who are at higher risk of being infected will be priority in receiving the vaccine. We wanted to also make sure that we did not create any forms of inequity, so making sure that access to the vaccine was equitable and there are no barriers for anyone who is expected to receive the vaccine. Important also is the vaccine availability. As we have heard, there is limited supply of the vaccine. And also, the way the vaccine is stored in our clinics is not the same way that we store other vaccines. So it has a little time limit on how long it can be in our fridges in the community. So we have to be cognizant of that. Coupled with the low or limited supply we have, we want to really avoid wastage. So when it comes to our delivery approach, we felt that it's not going to be one hat fits all. We needed to take into consideration all the above factors and also think of our population demography and our geography in Winnipeg, and also to make sure that we do not, we have the vaccine available at multiple sites. We also have the use of multiple providers as well to be available to meet the needs of those who require the vaccine. And all this definitely will be communicated to both the general public and also the at-risk population, and make sure that everybody has the information they need so that when they have to access the vaccine, there are no barriers. Next slide. So this is just a little schematic diagram just to tell you what we have in mind. So currently we are delivering the vaccine via public health offices or an office, depending on how the case or the contact presents to us. And we expect that as the data evolves, either we have a case in Manitoba or the data from other jurisdictions reveals to us that we need to take a different approach or we need to expand the eligibility criteria from the province, then we would progressively expand the delivery to include community clinics, community sites that are targeting or cater to affected populations in addition to the mainstream population. And we just expect to build upon this plan as the data evolves or as the situation changes. Next slide. So current eligibility, this has been mentioned in Carol's slide. I'm just going to add a few points. We really are utilizing the eligibility criteria from other jurisdictions at this time because we don't have a case yet in Manitoba. The post-exposure, which is contact with a confirmed case or probable case, will also make you eligible for the vaccine. Remember, it's time dependent for those cases, so the sooner we know, the better, which really I want to reinforce the point that if you have a rash and you're not sure, you want to get tested as soon as possible so that we can get the results and we can do the contact investigation, identify the contacts on time, and be able to offer vaccine in a very time efficient manner so that we can offer that opportunity for prevention of disease or minimizing any severe illness that the disease might cause. Of course, you have to be asymptomatic to qualify or to be eligible. Currently, there are no main contraindications aside of you maybe having a bad reaction to the vaccine in the past. So definitely, if you've had a past reaction, we don't want you to have another one. There are some special populations that we have to take into consideration. Those would be on a case-by-case basis as to whether they can receive the vaccine or if they should receive the vaccine. That will involve consultation with different specialists. And this group includes those who are younger than the age of 18, who are pregnant or have an immune-compromised condition. Next slide. So what is our current process? Currently, public health is leading any case and contact investigation. We have multiple intake points. It could be from a doctor's office or primary care. It could be from health links, people calling to health links and asking, where can I get the vaccine? And then the call is redirected to public health. Public health will interview this particular individual, screen them and make sure they meet the eligibility criteria. We would offer the vaccine. And at the same time, because of the limited supply, there's ongoing monitoring and tracking of vaccine usage, and also monitoring and tracking, what kind of requests we're getting, and making sure that we are in ongoing constant communication with the province so that could inform any changes to the policy direction as to who should be on that eligibility criteria or not. Next slide. That's my last slide? Okay. I think that's it for me.
Okay, thanks, Bunmi, for that information. It seems like right now we might be more in a situation where maybe someone comes back from travel with a potential exposure. So maybe I can just ask, a few questions to try to help myself and potentially others understand the process and who might benefit from the vaccine. So clearly, if someone, say maybe they traveled to Montreal, had some fun, good on them, came back and they got a call from a partner, that partner was later diagnosed with monkeypox, what should they do?
Well, the first thing I would suggest they do is try and contact public health. Some people might not know how to contact public health, so health links would be a good number that I would recommend that people call. And health links usually would really direct that call to us. And then from there, the public health nurse will be reaching out to them to have a conversation, understand the exposure they had, and take information down as to dates and timelines, because the dates are very important for post-exposure, especially if the person has been told the person who contacted me is a confirmed case. So we really want to make sure that we are within the time period of 14 days, which is what is recommended now, to really to offer that vaccine. So we would be reaching out. Public health also would be providing all the education and helping that individual navigate the system, or if they have any concerns about, how to monitor for their symptoms or what to do. If they do develop symptoms, public health can support that individual in that way as well.
Thanks, Bunmi. And so if one of the community organizations, for example, had a participant come in and say, I'm worried about this recent exposure, that organization could potentially put them in touch with Health Links and help to navigate that until they get linked in with public health, is what I'm hearing you say.
Yeah, I think that's the easiest route. I mean, if people have a primary care provider that they want to go to as well, or contact, that's also another option. They can undertake if they know their public health office directly, because some people might have had a relationship. They have contact. They can also contact the public health office directly.
Okay, and now I'm just looking actually, because the slides referred a number of times to eligibility in the other jurisdictions, and Montreal has some different eligibility. For example, for men and gay, bi, or trans people who've had sexual contacts with at least one person in Montreal, regardless of whether that person was known to have monkeypox or not. So if we had somebody, for example, who went to Montreal and fit that eligibility criteria, could they also then call Health Links and be linked to public health and access the vaccine?
Sure, they can. Yes, we are honoring the eligibility criteria from all jurisdictions. Montreal, Toronto, Vancouver. I think Alberta too probably has one, but we are honoring those eligibility criteria.
Just an added question to that. What about the individual who plans to travel to Toronto, Montreal, and meets the eligibility for pre-exposure? So they're planning to go to a social venue or space and have sexual encounters, and they do meet the Montreal or Toronto pre-exposure. Would they be eligible in our jurisdiction before they travel?
I mean, my interpretation, and I'll let Carol weigh into it, they will meet that eligibility criteria. As long as it's the one dose, they haven't received any dose anywhere else, it's that one dose, they will meet it.
Well, and I guess what we just have to be conscious of is our vaccine supply. So I think we would like to get there and be able to offer that pre-exposure. But at this point in time, we're really looking at when they've returned. They could be eligible to receive the vaccine there as well. I know in those jurisdictions, anyone who's participating in risk activities, they would also be eligible to receive the vaccine there. But at this point in time, we're not doing that pre-exposure here, even though that's what we'd like to do, and hoping that we can get there soon.
Yeah, and I just want to say before we go on to some of the comments that are coming up, that there are some circumstances where people don't actually have to have sex in order to be eligible for the vaccine. So it's highlighted in bold on this website, for example, which is the Montreal Health website, that workers and volunteers at a GBT event or social gathering where there's sexual activity, whether you're part of that or not, are also eligible for the vaccine. So for people who are traveling to different events where there are potential exposures like that, helpful to be aware of that so you can access the vaccine either there or upon your return here in Manitoba, and potentially before you travel as the supply might increase or be available. So I'm going to go to some of the questions in the chat. There's one question from Albert McLeod around how people who are, I'm going to say, inadequately housed or unhoused who get diagnosed with monkeypox isolate, whether that's the winter or another season. Does anyone want to speak to the availability of alternative isolation accommodations or AIA?
Yeah, so I guess I could speak a little bit on that. And I have to say, thank you for the question, Albert. But now I'm thinking about winter, and I don't really want to think about winter yet. However, planning and preparing is always so important. So that is something that at the beginning, Marcia mentioned that we've been doing a lot of planning and have ongoing planning, continuing. And this is one particular aspect of the planning that is occurring right now, is about alternative isolation accommodations for individuals who have monkeypox and do not have somewhere that would be suitable for them to isolate. So just like with COVID, alternative isolation accommodations have been available. We are working on that process as well for people diagnosed with monkeypox.
Yeah, and so even now, my understanding is that is available using the same AIA process. And so people would be in contact with public health, like we already discussed. So public health could help facilitate that referral to AIA. We have a couple other questions here. Saturn says 000. The question is around how likely transmission is from contact with textiles like bus seats, bed sheets are something that we tried on, but they're asking about things like trying on clothes in stores, bus or airplane seats. Is that a significant risk or not?
What we've seen so far in the outbreak is that it really has been predominantly people who have had contact with other people, and mostly during that sexual contact. Theoretically, it could be spread like on clothing. I think the biggest risk is if you're a case at home and you have, active lesions and, your laundry, your bedding. But the likelihood of getting it on a bus seat or, someone where you're having very short contact with is really low, unless they have active lesions and you have contact with those lesions. So for the general population, the risk is really very low and not something that, we've seen in this outbreak. It's, most of the outbreak, it's really well explained by contact with others.
Great. I know we need to wrap up now because it's 2:59. There's not any other questions in the comments. For this audience, I just wanted to take a moment to remind them or advise them, ask them to follow Go Ask Auntie on social media. So Instagram, Twitter, Facebook. That's our new Indigenous-led sexual health testing, sexual supplies, traditional medicine around healthy and positive sexuality that's being led out of Ganiganichik and in partnership with the WRHA. So a great place to have all your sexual health needs met in a really culturally safe and welcoming space. So go follow Go Ask Auntie. We'll see what other information we can share even there about monkeypox as it continues to evolve. Thank you for putting the link to that into the chat there. And let me just also thank Santina, Carol, Pierre, and Bunmi for joining us today and sharing all of that information. Bye for now, everyone.